In 2018, there were diagnosed 2.1 million new breast cancer cases worldwide, and the 10-year survival rate now exceeds 80%, which means that women will live long lives with the direct consequences of cancer treatment. And nowadays, breast cancer conservative surgeries combined with radiotherapy has become the treatment of choice for the majority of patients with early breast cancer. In Europe, between 70 and 85% of patients are submitted for breast cancer conservative treatment, whether in the US the rate is between 50 and 70%. And 7 out of 10 will need an invasive preoperative localization technique, as the majority of these early breast cancers are non-palpable due to screening efforts in Western countries. But sometimes when we go for surgery, the outcome could be a positive margin. A positive margin means that the resection could be incomplete and we might need a second surgery. And worldwide, re-excisions rate range between 0 and 70% in the US, 17 and 56% in Canada, and between 12 and 30% in the UK, mainly due to incomplete resection, meaning that patients will need to go for second surgery. So how it is done, this process of preoperative localization? So when the surgeon goes for the operating theater, he has to know the exact position of the tumor, and he has to perform cognitive fusion. He has to correlate two-dimensional sectional images to 3D space for surgical planning. And we use the different modalities, imaging modalities for a diagnosis that are acquired in different positions and compressions. Look at the upper right image, a patient being submitted for a breast MRI in the prone position with the breast falling due to gravity. In mammography, the example below, you can see that the breast is being compressed in a totally different position. And as those are diagnosed in an early stage, in the majority of patients, most of them are also non-palpable. And that's why we need a preoperative localization to successfully remove the tumor in a breast cancer conservative surgery. And current localization techniques, they are all invasive procedures and prone to bleeding, anxiety, pain to the patient. So worldwide, the most used method is a wire guided. So a wire is stick inside the patient's breast to guide the surgeon during surgery. There are also other methods like carbon tattooing, radioactive seeds, technetium-99, and as I told you before, they are all invasive procedures. So the question is there a new way? Our challenge here at Champalimaud is to find healthy pathways for the implementation of technology in health that can be disruptive, but it also has to be ethical. So we started a study on how to build a digital breast model. And so we started this process with a study where we acquired patients with a surface scan, a GoScan 3D with the patient in the upright position. And then we acquired the patient at the breast MRI in the prone position. We have carefully annotated all the breast tissues in each MRI slices, as you can see in the pictures. And then we apply for fusion. And we have just validated this fusion using a methodology that we have published this here. So we wanted to make a correlation between the point A at the patient's skin acquired with the surface scan, and we want to make sure that that point correlates with the same point into the breast MRI. And here you see a simulation of the 3D reconstruction based on the MRI images, and you can see the simulation from the prone position as it is acquired in the breast MRI to the upright position to match the patient's position when she is acquired in the upright position. And this fusion technology allows us to see what is happening inside the patient's breast, as this video is very elucidative. So we just published a paper validating the fusion algorithm and the ground truth that we have achieved on a special issue of artificial intelligence in breast cancer. And then we just make a different experiment, acquiring the patient not in the upright position, but laying down in the operating theater bed. And we fuse this surface scan image with the breast MRI, excluding all the information of the breast MRI except the tumor that you can easily see in her left breast. And then we just wanted to make sure for what this technology could be useful. And well, now from now on, feasibility trials using this fusion technology can enhance clinical applications in different clinical scenarios, allowing to produce the next generation breast surgeon with the integration of augmented reality into the operating theater, allowing the surgeon a direct tumor visualization inside the patient's breast during surgery. So the new solution is Breast 4.0, a non-invasive digital preoperative localization technique that replaces standard invasive methods and potentially reduces re-excision, an enabler for surgeons to perform breast cancer conservative guided surgery with augmented reality that allows accurate tumor visualization inside the patient's breast. So the main application would be for diagnostics, so with a patient-specific digital model of a female breast, and then a clinical application in a real clinical scenario, just it is the breast cancer conservative surgery at the operating theater. So our solution is non-invasive and easy to adopt. It simplifies the patient journey, minimizing suffering and hospitalization time. As I said, this is a digital non-invasive method. No pain, no bleeding, no hematomas, no anxiety. And therefore, we could reduce costs and reallocate resources where they are most needed. Just for example, new drugs for better treatments. And here you can see a patient-specific 3D digital model of a female male breast after fusion between a breast MRI and the surface scan of the patient, where you can clearly visualize tumor location, size, and even shape. And so our solution gives the surgeons a digital approach with immediate and accurate interpretation of tumor size and location, thus a better tumor visualization during surgery using augmented reality in the digital operating theater. That will need to have 3D room mapping technology so this can be seen as a product. And then this will potentially improve clinical outcomes. So we have just validated our methodology January this year with the first assessment in the real surgical setting. So this is the view through the HoloLens of the patient-specific 3D digital breast model after synchronization with the patient laying down at the operating theater bed. And as you can see in this video, the surgeon is able to see where the tumor is before removing it. So the experiment was a success, and we validated that it is possible after producing this kind of models they can be ready uploadable to a HoloLens headset, allowing the surgeon to see the tumor inside the patient's breast. So yes, so this technology is based also in having this human-computer interface as it is as the HoloLens, the headset, which are essential. And actually, we can change the way we can see breast cancer on patients in a useful way using the HoloLens. So we use the HoloLens 1. We are expecting to receive the new model, which I already tried. It's lighter and more easy to use. And then to become a product, we just need the concept of a digital operating theater with augmented reality capabilities, so that The synchronization made by the surgeon could be automatic, and you can see the model viewed through the HoloLens headset perfectly synchronize it with the patient laying down at the operating theater bed. So the junction between artificial intelligence and augmented reality could impact these three different stakeholders. For clinicians, surgeons, it allows a rapid image interpretation of the breast cancer location in a real surgical clinical scenario. For patients, it means a digital non-invasive method, no pain, no bleeding, no hematoma, no anxiety. And for health systems, better clinical outcomes also result in reduced uh, health costs, and that can be helpful to reallocate these resources when they are most needed. So let's harness the power of REST 4.0 and the junction between artificial intelligence and augmented reality fighting against breast cancer. It was a pleasure to be with you and enjoy the rest of the session. Bye bye.